Hello, everyone. I'm Grant Hogue, and this is the latest episode of the Scoliosis Dialogues, the official podcast of the Scoliosis Research Society. The focus of this session of our podcast is this year's Douglas Burton Award-winning paper. As a reminder, the Burton Award is given yearly to the best adult spine deformity paper published in our journal, Spine Deformity, and this is the second year of the award. This year's Burton Award-winning paper is entitled Knee Flexion Compensation in Postoperative Adult Spine Deformity: Implications for Sagittal Balance and Clinical Outcomes. This is a paper out of Columbia, and we are fortunate to have a few authors from the paper with us for the podcast and the discussion. I'm going to allow our authors, Dr. Sardar and Dr. Lenke, to introduce themselves before we get started. Dr. Lenke, you want to tell us a little bit about yourself and your practice for anyone who doesn't know you if they've been living under a rock?
Good evening, Larry Lenke. I'm a pediatric and adult spine deformity surgeon, Columbia University, and co-director of Spine, our spine program affiliated with New York Presbyterian Hospital System in New York City. And obviously a very proud SRS member and very proud past president in 2010 of this society, great society. So glad to be here tonight.
Thank you.
All right, I'm Zeeshan Sardar. I'm also one of the spine surgeons at Columbia. Dr. Lenke is a younger partner. I have a lot of interest in adult and adolescent deformity, especially sagittal alignment. I've been an SRS member since I started practice, and hope to continue to be involved in SRS as my career goes forward.
Excellent. And just for anyone who maybe read the paper when it originally came out and isn't quite up to date with exactly what's in the paper, would one of you give us a little bit of an overview of your methodology findings and anything else you think is important to know?
Yeah, I'll do that real quickly. So basically, we looked at a really large sample of patients from our center, 263 to be exact, all having 2-year follow-up following major adult deformity surgery, and basically looked at them and separated them into 4 groups based on 2 variables. First variable being their overall global sagittal alignment, and that was based on the cranial SVA to the hip axis being less than or greater than 20 millimeters, either aligned versus malaligned, and then also what we considered called a KFA or knee flexion angle, being malaligned knee flexion if it was greater than 10 degrees. So based on those 2 variables, we separated patients who were basically at early post-op and 2 years post-op, kind of aligned cranially to the hips, and either not aligned or aligned regarding their knee flexion angle, or malaligned regarding their cranial axis of the hip, and either aligned or malaligned regarding their knee flexion angle. So there was 4 groups produced. And kind of not surprisingly, what we found is that the patients who did the best as far as least amount of overall revisions in the 2-year time frame and overall better outcomes were those that had optimal sagittal alignment with minimal to no knee flexion, basically. So their knees were straight and their spine was aligned globally. And those that are the worst were basically those patients malaligned globally as far as their sagittal axis, their cranial axis of the hip, and also had concomitant knee flexion greater than 10 degrees of angulation. And then kind of the 2 groups in the middle that were either sagittally aligned and had knee flexion angle or had no knee flexion, but were malaligned. They did intermediary, but of interest, interesting, the patients that were sagittally aligned but had some knee flexion angle greater than 10 degrees, they did well early on, but by 2 years post-op, they had a higher revision rate. So the kind of gist of the story is that if you're just looking at your overall patient global alignment and not taking into their knee position, especially any knee flexion, that you may kind of not truly appreciate the surgical outcomes, because again, patients who were globally aligned in the sagittal plane, if you just look at their cranium to their hip and pelvis, and if they were well aligned, but their knees were flexed, they didn't do well at 2-year post-op. They had a high complication rate, just like patients who were malaligned globally. So we just can't take into consideration spinal alignment. We have to take consideration what's happening in the lower extremities, in other words, to make a full assessment of the patient, to correlate with not only revision rates, but overall outcomes as well.
So I think that's a really important point that you make about looking at global alignment with the lower extremities as well, because before this idea, I can imagine where many surgeons would look just at their spinal alignment and say, "Oh, this patient looks great. They're going to do well." And then a year and a half, 2 years, 3 years down the road, the patient's struggling, maybe needs a revision, and you're asking yourself, "Man, I thought this was so great." And so now having this extra piece of data potentially gives surgeons something else to look forward to, or maybe to fear in the future. And so was that really the genesis of this investigation, you noticing over time the way that patients were compensating?
Yeah, so especially early on, early post-op, patients, we normally get upright total body images even before they leave the hospital. 4, 5, 6, 7 days post-op, and obviously we often noted some knee flexion or other compensation just because they're still recovering from the major surgery, and even by 6 or 8 weeks post-op, we thought that may still be a residual of the recovery, but it really wasn't. If they're the point was, if they're still flexing their knees in your 6, 8, 10-week post-op X-rays, that they really should be recovered by then, and it's probably a pathologic sign. And maybe I'll ask Dr. Sardar to kind of comment on. We have data on what kind of normal knee flexion should be in volunteers, and as a contrast. So, Zeeshan, you want to talk about that?
Yeah, thank you, Dr. Lenke. So just to add on the knee flexion angles, what we did was we've also looked at a large cohort of asymptomatic individuals. We published a few studies on that. They fall under the MEANS study group, which stands for essentially the multi-ethnic asymptomatic normative study. And so the goal of that was to look at alignment in asymptomatic volunteers, not necessarily normal spines, but patients who are asymptomatic. They were from ages 18 to up to 80. And within that cohort, we did have EOS imaging for all of those patients, and we had also analyzed their lower extremity axis, and we did look at the knee flexion angles. And what we saw was that on average in that cohort, the knee flexion angle was actually just a tiny bit of extension, about minus 2 degrees. So a little bit of extension as a whole cohort. But the standard deviation was about 5 degrees. So if you kind of take that into 2 standard deviations and add on to that they're starting with a tiny bit of extension, you end up with the knee flexion angle of up to 10 degrees that falls within 2 standard deviations. So I think if you look at this paper as well, that references that we use 10 degrees as the cutoff for knee flexion. That kind of comes from not just our study, but for other studies as well, looking at asymptomatic patients, where we see that within 2 standard deviations is about 10 degrees of knee flexion. Interestingly, in the older cohort, in the older patients, asymptomatic as well, there is a little bit more knee flexion. They go from a bit of knee extension to about 3.5 degrees of knee flexion. So there is some increase in knee flexion with age. So just considering all of that, what the study then looked at was that more than 10 degrees is what we consider to be abnormal for our cohort in the symptomatic patient groups, to see how these patients are doing then after surgery. And to add to Dr. Lenke's point, I think again initially we used to think that by 6, 8 weeks they might still be trying to rebalance themselves or whatnot. But it's true, by 6 to 8 weeks, if they've still got their knees flexed, it may be a sign that even though if you just look at the spine, they may look aligned, but overall they may not be aligned, and they're still trying to compensate for that. And so that's where the knee flexion comes in. It's really, we think it's a compensation, right, for the residual malalignment where these patients are post-op.
patients had a higher revision rate and weren't satisfied. So it's critical early on to examine them. We didn't have any follow-up whether we should be more aggressive and maybe revise some of those patients to get even better sagittal alignment. But that's kind of the implication, right? I mean, of that. We don't know. I think that's obviously kind of difficult, and it really depends on a lot of factors. But I think it's so important because we make all our decisions on our outcomes radiographically on radiographs that include the cranium to the hips, but that's not enough. That's the main message of the paper. You need more.
Yeah,
So you
absolutely.
bring up an interesting point. You use the EOS imaging system to get head to toe images. And I think there are probably a few other companies that have kind of a head to toe slot scan, but seemingly it would not be possible to know this information without this type of x-ray. And I'm not looking for a former president of the SRS to give us a hot take on what everyone needs to have in their office. But do you think there are other ways to gather this data if someone doesn't have access to this type of radiograph? Can it be done with a careful, gentle, physical examination and a goniometer?
Probably. I mean, that's probably not going to be as accurate, Grant. Certainly before we EOS back in the 90s, I didn't have EOS in the 90s. I started having, I think, EOS scans probably 22 years ago, I think, when I was back in St. Louis. But, we looked at the patient clinically as whether we asked them to stand comfortably and see, if they did have knee flexion. And conversely, what we used to do to try and kind of replicate what was best for their standing posture radiographically, we used to put them in knee immobilizers and try and forcibly straighten their knees and see what result in sagittal malalignment we produced by that in those patients that were compensating. So we often Keith Bridwell and I often did that back in the 90s, is to quantify someone with straight knees and then kind of forcing them to produce their maximum sagittal malalignment. But that wasn't ideal either, obviously. But maybe with a goniometer and you can do some of this, or maybe with separate knee X-rays, you can get some of this information. But it really shows. I mean, going forward, obviously, it's not practical for every center to have total body imaging, but it really is important to examine the patient kind of skull to feet when you're doing a deformity realignment, especially in the sagittal plane.
Yeah, and I was just going to add to that. I think just like Dr. Lenke said, it may not be that everyone needs to have an EOS, but we do need to have a method of measuring the knee flexion angle prior to surgery, whether it's a separate X-ray or clinical is very difficult. It is difficult to do that. It's difficult to reproduce that. It's difficult to get the right angle of the pictures as well than if you're taking pictures and measuring them later on. So I think it becomes a bit more difficult clinically. But some form of radiograph, whether it's just a straight, lateral across the knees for the patient in the same standing position to measure that, because we also know that now, as we're looking at the true pelvic tilt that the patient has, knee flexion compensation becomes an important factor in trying to predict that. So, if we know the patient's knee flexion, we can also try to accommodate for that to try to understand really what their pelvic tilt should be as opposed to what we're seeing right now, because that's already compensated.
So you mentioned that is a point of looking at their knee flexion and how they're compensating in the preoperative state.
Right.
And so, in addition to knee flexion, were there any other preoperative factors that came out of this that made it more likely for someone to need knee flexion? And if so, are these factors potentially modifiable preoperatively by the patient, not just intraoperatively by the surgeon?
I'll start with that. Typically the first compensation patients have with sagittal malalignment is pelvic retroversion, right? Increasing pelvic tip, pelvic retroversion. So normally knee flexion occurs after that. So you first kind of slightly kind of rock your pelvis back as the first compensation, and then if that's not enough, that's when you start slightly flexing your knees. So in other words, if you see a patient in knee flexion, they usually are someone that's already starting to max out their pelvic retroversion, right? So you have to be really careful. In other words, they need more sagittal realignment, right, is the bottom line, if they're already starting to flex their knees. But again, so that's maybe something to think about if you don't have total body imaging, that if you're just examining your patient and they seem to have some knee flexion, ask them to straighten their knees, or even slightly extend their knees and kind of see what happens with their sagittal posture. And if it goes forward, as it probably will, and you probably need to plan on a bit more sagittal realignment, than you were planning if you didn't realize that they're slightly flexing their knees. So that's maybe something that can be a take-home message, is that if you don't have the ability to see the knees radiographically, that clinically make sure that their knees are near extension when you're examining them. If they're not, then trying to make sure they stand in extension and to see what happens to their trunk, right? And maybe consider getting an X-ray like that to try and quantify, where they are with slight knee flexion versus, knee extension. And honestly, that's kind of what we did back in the 90s, as I mentioned, before we had total body imaging.
So along those lines of planning your surgery, for these types of cases, how often are you using different preoperative planning software? And do you think that eventually that type of software would be powerful enough to take in, preoperative knee flexion as one of the data points when you're building in your sagittal parameters?
Zeeshan, you want to take that?
Yeah, of course. Yeah, I mean, I think so. To answer your question, essentially every case that we do now, we are using preoperative planning software, and the reason for that is, obviously, the fact that it's not just the knee, it's not just the hip, it's not just the pelvis. There are so many different alignment variables to look at now, and then at the end of it, even though we're doing calculations and everything, I think the visual representation of what we think it's going to look like also makes a huge difference. So yes, every single patient that we operate on, essentially we do plan with the planning software. Currently, as you said, planning softwares are not really taking into account, or at least the ones that we're using, are not really taking the knee flexion into account. And you're absolutely right. I think as we learn the effect of knee flexion, and precisely on the alignment, we would start to incorporate that as well. And I think, as we start planning things more and more precisely, we have to take that into account. We have to take into account how, if the patient was not flexing their knee, their malalignment would look like, and how much we need to correct. And as we just heard, one of the biggest pre-op factors for post-op knee flexion was pre-op knee flexion, right? So so that kind of tells us that patients are coming in flexing their knee initially. If we don't, in a way, not necessarily overcorrect, but if we don't account for the fact that they're already compensating for the alignment that we are seeing, so we may have to give them more correction, then they may end up keeping some of that knee flexion. So I think that's in a way somewhat important. Other factor is also, I think age is a factor there as well. Some of the patients who did have knee flexion pre-op and post-op in those groups, they were on the older side compared to the other ones. So maybe there's some age factor, but I do think that, as we kind of go along, and the software becomes more sophisticated, that it should start taking the knee flexion into account for planning as well.
Excellent. And so I've got one final question for the two of you. And Dr. Lenke, you alluded to this a little bit earlier. And so if nothing ruins good results more than follow-up, when you see someone now who's well aligned but has knee flexion, what is your conversation with that patient? And are you at a point in trusting your data in that you would be proactive enough to offer them an early revision?
Great question. I think my first option would actually have them work with physical therapy, potentially to see if they can have some reserve in their pelvic retroversion and overall kind of realignment to see if we can improve their knee flexion with therapy and overall sagittal alignment. So, if they're both flexing their knees and they're malaligned, I'm probably going to be a little more aggressive maybe with an operative side, but I think, even when we're talking about maybe planning a revision, I still would have them work with therapy. I think therapy when her, because again, I said we did have a subset that had overall good sagittal alignment, but still had knee flexion. So that's the group I think I would kind of really push to get into a therapy program pretty quickly. Those that have both suboptimal global sagittal alignment and knee flexion, those patients are probably headed towards a revision, I think, sooner than later at our institution. And maybe if it isn't planned, it'll be unplanned once they have a pseudoarthrosis or implant failure, right? So, but that, like, that wasn't that wasn't a large portion of patients, it was 10% or so, but it does happen. I mean, part of it is, I think, because it's what Dr. Sardar mentioned, and we don't, even though we plan, we don't take in consideration absolute planning software of the lower extremities. So, you have to kind of dial in a little bit more aggressive realignment if patients have knee flexion, right? Even though it's not being quantified by the software, any software that I'm aware of right now. So, I think that's where we still have a ways to go to get this perfected.
Yeah, and I think, and just to add to that, and if you look at the data in this paper, those patients who were malaligned and had knee flexion post-op were actually the ones that also had three-column osteotomies, which means that we were planning on giving them a lot of correction, but they were just so malaligned to begin with that there is an extent to how much we're going to bring them back with the one surgery, and it's difficult to just tell them at 6 weeks, hey, we're going to do another one, right?
Right.
And so you kind of let them, let things kind of declare itself. And again, it's not that everyone in that group is going to need another surgery. There's a proportion
Right.
of that, just higher than the ones who were really well aligned. Right? But I think the key is that the patients who were malaligned and had knee flexion, if you look at the pre-op, they were extremely malaligned pre-op. And so they're starting off just so worse off from the alignment that even though we increased them a lot and their ODIs and everything improved a lot, of course, it's difficult. They're still not perfect because they're starting from such a poor starting point.
But their delta was well improved
Yeah.
still, right? So
Yeah,
they're happy, but as long as they heal, and they're pretty satisfied patients. Yeah, good point.
Yeah.
Well, I want to thank both of you for doing this podcast. Thank you both for your clinical work and for this research endeavor. If it was easy, everyone would be doing it. And so it means a lot that you're doing research like this for all of us to read and learn from. Any final thoughts that you'd like to share with the audience?
I think points we discussed are pretty straightforward. Just be aware of the knee position in patients you operate on if you don't have total body imaging. So that's very important.
All right. Thank you so much. Everyone who's listening, hopefully this comes out before the SRS abstract deadline, but if not, get your SRS abstracts in. I believe the deadline is February 3rd.
Thank you very much.
Great. Thanks, Grant.
Take care.
Thank you.